Now we are moving on to the fifth symposium for the day, and it is themed on respiratory infections. Today we have some dignified dignitaries who are here to enlighten us with certain respiratory infections that are very common in the world today. But before we move on, I'd like to cordially invite the chairpersons for this symposium, and I'd like to invite Professor Inoka Korea, consultant microbiologist from the Department of Microbiology of the University of Colombo, and Dr. Bandula Gunasena, consultant respiratory physician at the National Hospital of Respiratory Disorders, to come up on stage to chair this symposium.
Good afternoon, everyone. I think my co-chairperson is not available, so I will go straight ahead due to the time constraints. So Symposium 5 is on respiratory infections. And before we start, I'd like to thank all the speakers for agreeing to speak at this symposium. And also to remind the speakers that each talk is for 20 minutes. And there is a display of time that will warn you when your 20 minutes is up. And we will go with the 4 speakers, and then we will have time for question and answer. So let's start with our first speaker for the day. Maybe I could invite both speakers who are present here onto the podium. That is Dr. Dhammika Vidanagama and Dr. Kirti Gunasekara. So we begin the symposium with a talk on new diagnostics in managing respiratory infections. Will cultures become obsolete? And the speaker is Dr. Dhammika Vidanagama. Dr. Dhammika Vidanagama is the consultant microbiologist at the Lady Ridgeway Hospital for Children.
Okay, thank you very much, Professor Inoka. Thank you, College of Pulmonologists, for inviting me to do this talk on this interesting topic. It's a challenging one actually, because as microbiologists we are very much familiar with bacterial cultures. So my talk will be on 4 sections. I'll just spend 1 or 2 slides to talk about the impact of respiratory tract infections, which you all have been talking about during the day and tomorrow also, and the challenges in the diagnosis. Most of the talk will be on the diagnostic methods on laboratory confirmation of respiratory tract infections and guiding you on therapy, antimicrobial sensitivity testing. And we'll have a few slides on the discussion on the way forward. And as respiratory tract infections, we don't have to talk much about morbidity, mortality, because from yesterday you were talking about how it affects your patients. They are very common infections causing consultations, admissions, antibiotic prescriptions, and deaths. And looking at it in a different way, the loss of life expectancy is significant, because infectious disease deaths up to 46% are due to some respiratory infections, and about 1.29 years of loss of life expectancy globally, especially in extremes of age, and we say men and populations in low and middle income countries are disproportionately affected by this, with higher losses of life expectancy. And the challenges here are that respiratory tract infections, it's not one infection, because it's a spectrum of many different diseases. And patient populations are also different, because maybe from neonates, premature neonates, up to the extremes of age, elderly, and pathogens are vast variety. You can't just make a list of those, but they are not only very many, but they are evolving also. They don't remain genetically the same. They will be evolving, and they will be crossing species barriers. They will be coming from animals to humans. And we have seen the impact very well during the last 2-3 years. And some of those are very much transmissible. They will travel the globe very quickly, and then from patient to patient and throughout the community and healthcare settings also, we have experienced all these things, outbreaks and pandemic potential. And the other thing is, when these things, infections are there, invariably you use some antibiotics, antimicrobials, and then you face the threat of antimicrobial resistance with its ongoing not only health impact, economic impact as well. So the diagnosis, we have already, clinically you know when the patient comes, you assign into some box, some syndrome, maybe upper respiratory tract infection, lower respiratory tract infections, pneumonia. So the syndromic diagnosis and algorithms at the clinical level, and then you need the help of radiology. Many different imaging techniques and diagnostic procedures are there. Coming to the laboratory testing, we see routine tests that we do commonly, the full blood count, inflammatory markers. They will help you to get some idea, and some biomarkers of different types of bugs will also be available, like galactomannan, if you, and there are several markers. But the confirmation of pathogen, what is the type of pathogen, what is the organism causing this infection, that is the most important thing. And then you can go up to different levels, the genus level, the species level, or even to the level of typing. And AST is also important to guide therapy. Finally, there's no point if it's not helping the treatment. And which pathogen, which antibiotic, which antimicrobial resistance patterns are there, and then how to give the doses, routes, and durations. Those also depend on your laboratory diagnosis. And then in some populations, you will need some special testing, especially the immunocompromised population. And then you have to make some decisions on isolating patients, prevention, and sometimes the diagnosis will guide to vaccinations as well. So you have several indications for the patient management, for the prevention of infection, and prevention and control of antimicrobial resistance as well. So in the diagnostic stewardship, we have these pre-analytical challenges, because it will, all the diagnosis, whatever the method you use, it will depend on the type of specimen. If it is not of good quality, if the quantity is not adequate, it's not going to give good results. And then the test that you use, and then the infrastructure and how you have established the test is also important. The quality assurance, if the test is not performed properly, that is going to affect the result. After getting the result, the interpretation is also very important, because the respiratory tract is always having some colonizers. So if you get a report on colonizers, you are going to treat unnecessarily, and there will be the aftermath of that. And then ideal diagnostic test, which is still not available to any one of us. So we will talk briefly about the conventional approaches, the direct diagnostic methods, starting from microscopy, and then talk a little bit about cultures. Microscopy, we have started, I think, centuries ago, still remains in some diseases like TB, AFB, we are still talking about, because molecular diagnostics are not available throughout the country. And then you have to think about advances in microscopy, like fluorescent microscopy and electron microscopy, which are not very much clinically useful. And there are rapid immunoassays that you use, latex agglutination tests and all those things. Directly from the specimen, you detect the antigen of the organism that will help you to identify. So they have different sensitivity and specificity for different types of pathogens, mainly used for pathogens that we can't culture in the lab, like influenza. The direct diagnostic testing sometimes will be useful with different medium specificity and sensitivity, but it's definitely going to be easy to perform. And you have all heard about this urinary antigen detection test for pneumonias, pneumococcal pneumonia, and legionella antigen for Legionella pneumonia. And again, this TB diagnostic test in urine in some populations defined by their CD4 count, the lipoarvin in urine. Direct antigen detection for viruses was the familiar and most popular method for respiratory specimens which we have used. And it was a bit cumbersome method, because you need a fluorescent microscope, and then various commercial kits are available for different types of viruses, because it's not only one virus that you are going to look at. Because if you look for influenza, if it is not positive, then you have to keep on looking for other viruses. So you need a panel of different kits and different sensitivities. So these require technical expertise for accurate interpretation, and results can be subjective. These were not performed at routine clinical laboratories. Mainly when if you send samples to medical research institute, you could get a result in a few days. So the limitations are they are significantly less sensitive when we compare with the molecular methods, and then RT-PCR detected 40% more positive more samples from pediatric patients when you use in comparison with the fluorescent antibody assay. So we all prefer to use PCRs. And talking about serology, that may be useful in some organisms when we can't culture the bacteria, and when satisfactory PCRs are not available those days, like mycoplasma antigen antibody test, because the problem here is the sensitivity and specificity is very variable, and then we have limited usefulness clinically due to delay in antibody response, because you will take some time to detect an antibody response, IgM response in your patient. By that time, the patient, before that, you will need some form of treatment to the patient. And then limitations in specimen collection, sometimes you have to show a rise in antibody titer that will need 2 specimens. That is also a limitation. So coming to the culture-based methods, those are the traditional gold standards in bacteriology. And fungi and some viruses also you have to go for cultures, and isolation and identification is necessary for the antibiotic sensitivity testing in the traditional methods. But more and more newer technologies are becoming available now, because we have automated blood culture systems that will help in your patients with severe pneumonias. The blood culture positivity is going to tell you which bug is there, and you can get the AST as well. And identification and DST is also getting automated. Routine laboratories are, clinical laboratories are using these techniques, and then mold it off, though not available in Sri Lanka, for the identification of organisms. Once you have isolated the organism, that's important. And then for viruses also you have modified cell culture methods that will give you a quicker result than the traditional cell culture methods. And then the sensitivity again depends on pre-analytical factors. And then if the specimen is not previously assessed for the satisfactory nature, sputum especially, if the patient has not given a good quality sputum sample, you are going to get rubbish, because it's not useful. So all the labs are recommended to do the sputum quality assessment before going on with the culture. And then specimens collected after antibiotic exposure, that again will not give good result. And cultures are cumbersome, they need complex, labor intensive and technically demanding. On top of that, you will not get your culture result within your expected time period. It will take at least 48 to 96 hours. If it is not a good quality specimen only, you will get your culture result saying that it's not a good quality in 24 hours. And turnaround time is high, and then some pathogens, as you know, it's going to take a much longer time. Comparing cultures with PCR, when we need a prompt diagnosis, definitely PCR assays are considered the new gold standard diagnostic method, especially so for viruses, as well as when you have bugs which we cannot culture in the routine laboratory. But still, bacterial pathogens generally need culture isolation for the sensitivity testing. And when there are cultures, organisms, when you can predict the sensitivity pattern with a single step PCR, like strep pyogenes, you know it's not going to be resistant to penicillin. So it's predictable. So the PCR for single step, it's good enough. And if it is MRSA, if you have the correct targets to detect the MRSA, you are not going to need another sensitivity pattern also. But for the other organisms which has multiple resistant patterns, you will have to have some more testing to predict the sensitivity. So what are the newer approaches? The molecular methods available play an essential role in the global health response. As we all saw, everybody, every household, everyone wanted to get a PCR done for COVID. And then highly sensitive and specific ones were considered the gold standard in the diagnostics. And then the variety of nets with differences, you have so many different types. Pathogen coverage, the number of targets covered, maybe it's they're going to detect a single pathogen or many pathogens can be detected simultaneously. The assay chemistry, complexity, the methods of amplification, you will see so many different varieties of newer molecular platforms, and performance will still depend on the pre-analytical factors, and still they will need some interpretation in post-analytical factors. What are the advantages actually? For SARS-CoV-2, we all saw how very useful it was. And for influenza, you can reduce the unnecessary antibiotic use and improve antiviral prescribing if necessary only, and limit additional testing, and shorten the durations of stay and emergency department stays, and optimize infection control practices also if you get this rapid molecular testing for influenza in our lab, in our OPDs. If it is a point of care test, I'm sure many of you will like it. And then if you can test for multiple respiratory viruses simultaneously, that be much the better. You test for all the bugs at the same time. So you have the new multiplex respiratory syndromic panels, which is the most advanced thing available now. So there are so many different types, different in complexity, throughput, pathogen coverage, and ability to subtype organisms, and workflow, and ease of use, and time to result. There are different types. And when you compare with viral cultures, definitely diagnostic yield will be greater with higher sensitivity and specificity. I decided to speak about only one type, one example. This had the highest number of pathogen coverage. About 27 pathogens are covered in this type of film array biofire assay. About several pathogens are semi-quantitatively detected. They will give you a quantity because these are the pathogens which will be sometimes there as colonizers. So it's useful for you to know the quantity, because the higher quantities may indicate the infection, lower quantities may be due to colonization. And then qualitative detection of true pathogens like Legionella, and some of the viruses are also detected. Then some resistance genes are also detected in this assay. About 7 resistance genes are there. So this might be one of your wish list if you are wishing for a good diagnostic. And then how useful are those panels actually? So they will decrease the time to diagnosis, they will optimize the use of antibiotics and shorten the duration of stay and so on. But the cost and some of the performances for some of the pathogens is not that great, because it's not uniformly sensitive and specific for all the different bugs in the panel. And you might sometimes face difficulties when your assay gives you more than one pathogen. So whether it's a co-infection, whether it's cross-reactivity, you will have to answer those questions. So the ideal diagnostic test, there's no single test, no single approach, but we'll have to see of the test or algorithms best for the situation. And the ideal diagnostic test will have to optimize the diagnostics of all the types of viral and other microbial diseases, and then obtain useful, cost-effective and labor-saving workflow to be successful and sustainable in our laboratories. We have to consider the patient population and clinical manifestations, the syndromic approach depending on the severity of the infection, and the epidemiology also will have to be considered. So for the questions for discussion, we have to see when to test or when not to test. You don't have to test all of your patients coming to you with respiratory tract infections, and then which panel or the algorithm and interpretation and other benefits. So clinical decision making influence, severity of illness, and all those will have to be considered. And then you have to consider the pretest probability, because if your pretest probability is low, you are going to get more false positive results. It's recommended that if you have an intermediate pretest possibility and intermediate disease severity, that is the best situation for you to go for these assays, because if you have very high pretest probability and very high severity, you are not going to wait for a test result. You are going to have to treat that patient. So this is the recommendation of the IDSA for the intermediate pretest probability and intermediate disease severity to choose your patients for these assays, and then you have to again think of availability of resources and prioritizing. You can't do the tests on each and every patient, and it's not useful to test each and every patient who will come to you for all these types of viruses and bacteria. And then the other indications, it's not only for the patient management, there are some other indications like surveillance. If you have to study the epidemiology of the disease or infection, and you may have to make decisions on vaccines and stopping antibiotics you will have to use. And then for a test, you have to think about technical and diagnostic accuracy, diagnostic decision efficacy, therapeutic and procedure changes that you are going to do depending on the result and the patient outcome, and societal perspectives on testing. So there may be a hierarchy of testing and for a limited population of patients. So NATs may detect more bacterial pathogens than culture, it's obvious, but you may detect some dead organisms because you are going to detect only DNA or RNA. So that is one of the problems. And then maybe you can get NAT positive, the PCR positive, culture negative results, again after using antibiotics. And again, neither culture, no NAT separates colonization from the true pathogens. So again, you will need some interpretation there. So benefits of NAT will be on antimicrobial stewardship, because that is another use that we use. Rapid testing will definitely help you to stop antibiotics if the patient is having a viral infection, and then but still you need so many factors, because to convince the stopping of antibiotics, even if the PCR is showing a virus, again you have to show that bacterial cultures are also negative, and then chest imaging is normal. So other issues also may be there when your cultures are detecting many other organisms, and then so it's not a single answer to your question. You have to think of many different factors and use the testing algorithms. Thank you.
Thank you, Dr. Vidhanagama, for that interesting talk, and also for sticking exactly to time. We'll move on to the next speaker. The title of the talk is The Clinical Spectrum of Pulmonary Aspergillosis, and the speaker is Prof. David Denning from the UK. He's a professor of infectious diseases in global health from the University of Manchester in the United Kingdom.
Good day. My name is David Denning, and I'm going to speak to you today about the clinical spectrum of pulmonary aspergillosis. I want to first just highlight the significant problem with mortality from fungal infections globally. There are about 1.5 million patients who apparently die of TB every year, although we think some of those are fungal deaths. And then there's been a rising number recently of malaria deaths, about 600,000. But we think there's over 2 million people who die of a fungal infection every year. So it's a substantial problem and relatively underaddressed. A couple of general comments about fungal diseases. A few of these diseases, you can actually see some cutaneous infections, and you don't need a test to be able to make a diagnosis and can proceed with therapy. And radiology is very helpful for aspergillosis, but it's not definitive. You don't know which fungus it is, you don't know if it's resistant, and you can't always be sure that actually it's aspergillus at all. And I'll show you some issues related to tuberculosis and aspergillosis. There are lots of different sorts of tests. Antigen and antibody are generally more sensitive than culture. Microscopy is less sensitive, but quite definitive when it's positive. And then there are PCR molecular tests and, of course, histopathology. And several of the antigen antibody tests are now simple new point of care tests, or they can be done in a laboratory varied by any technician. And those have really revolutionized diagnosis for fungal diseases, and they need to be implemented across the world. Microscopy is good, but it takes a lot of skill and often time as well in the laboratory. And given the shortage of laboratory workers, that's sometimes a challenge. And fungal identification can also be difficult and requires considerable skill. And PCR is harder for fungus than it is for viruses because fungi have a thick cell wall and there are many fewer infecting fungal cells. So the sensitivity of PCR for fungus, while it's good and often better than culture, it's not as easy as it is for virology. So some years ago, 5 now, we had a meeting in Kampala to address the issue of essential diagnostics for fungal disease. And as a result of that meeting, we've persuaded the WHO to accept a group of fungal tests as essential. And these are listed here. You'll see that it's now 2 years ago, Aspergillus antigen and Aspergillus IgG antibody were both accepted as essential tests. And every country should have access to these tests, and clinicians should be familiar with their use if they're treating these types of patients. So invasive aspergillosis, it does appear that about half the patients in developed countries, the cases occur in intensive care. We think about this as a hematology neutropenia problem, and that's still significant, particularly if antifungal prophylaxis isn't given. But in numerical terms, actually ICU is where the majority of these patients occur. And the problem in intensive care is that the radiology is not very specific. There are many, many abnormalities in these patients, as you well know, and I don't need to explain it. So on this, these are all patients with invasive aspergillosis, but the findings are not very definitive. Bottom left, you can see these nodular appearances with a little ground glass around them. That's the most obvious of these cases, but otherwise it's a little tricky to be sure. We've had a big problem with invasive aspergillosis in COVID, and this was one of many, many papers published from France of 246 ventilated patients who were thought to possibly have aspergillus, and tests were sent to the laboratory, and they also had a worsening clinical status. They did quite a lot of tests on them, including PCR and galactomannan or antigen testing on BAL, and they also looked for pneumocystis. And they found that 19% of these patients, so deteriorating in intensive care, had invasive pulmonary aspergillosis, and their mortality was 70%, compared with the mortality in those without aspergillosis of about half that. And the reason that ICU patients get invasive aspergillosis is because they have an episode of sepsis, usually, or some other significant medical surgical event. They end up in ICU. You get a Th1 immunological response to that. And then in order that the patient doesn't die of a toxic shock-like syndrome and excessive Th1 responses, that's damped down by a 2H2-like response. And sometimes that gives you a depression below the baseline in terms of immunity. And so you end up with this, what's called CARS, or compensatory anti-inflammatory response syndrome, or immunoparalysis. And that's the time when you get candidemia and invasive aspergillosis. And the baseline rate of invasive aspergillosis in medical ICU patients in Europe, anyway, is at 2 to 5%. So 1 in 50 to 1 in 20 or so of your patients may well have invasive aspergillosis. And so it does need to be actively looked at in that group of patients. The other substantial group of patients is patients with COPD. And of course, some of these end up in intensive care. And here are some radiological examples, some odd shadows in a COPD exacerbation patient with multifocal. Sometimes it's a bit clearer, as in this example, with a ring and cavitation, or just nodules, as in this. But sometimes it's just an area of consolidation. It's usually bilateral. Sometimes you'll grow aspergillus. Usually they will not have a fever. So it's a very quiet infection, this, and you wouldn't expect a significant inflammatory response. And it's relatively common. So this case control study from southern China looked at about 300 admissions to hospital with COPD. 60 of those grew aspergillus, and overall they reckoned about nearly 4% had probable invasive aspergillosis and 40% died. And the other point to make here is that these patients don't all have standard risk factors such as neutropenia, such as steroids. Only 13% of the patients in this group had oral steroids. So the COPD itself, the lung disease itself, is a risk factor. So in ICU, you can make a diagnosis in different ways, but in a group, one of these early pivotal studies, 26 proven cases, the sensitivity of galactomannan antigen testing in BL was nearly 90% sensitivity and specificity, whereas culture was only 40% sensitive. So we do know that if you can take a non-directed BAL or the directed BAL or even a tracheal aspirate from patients in ICU and look for antigen, you're likely to be able to make a diagnosis. And there are these, as I pointed out, there are these point of care or lateral flow tests that you can use. This one is slightly simpler than the galactomannan one, possibly slightly less sensitive than the galactomannan one, but it's still a useful, quick test for diagnosing invasive aspergillosis. The other point to make is that cultures are normally done using methods developed decades ago for bacteriology, so that you could pick individual colonies of pathogenic bacteria such as Haemophilus or pneumococcus. But what that means is a lot of dilution of the sample. So if you use a high volume fungal culture, as in this example on sputum, you get very much higher yield of fungus. And this was shown in a small study in Pakistan, where the rate went from around 17% to 70% yield by culture. So high volume culture is also helpful. So how do you make a diagnosis of invasive aspergillosis? And you can see the brown and green marked areas of the tests that are most useful. So antigen on BAL, antigen on serum in particularly neutropenic patients, but it is sometimes positive in neutropenic patients, in non-neutropenic patients as well. Beta-D-glucan is around 50 to 70% sensitive and not fully specific because it comes up with pneumocystis and candida. And then PCR is helpful in many patients as well, although the data for PCR is not as good. Culture is less than 30% sensitive in invasive aspergillosis. Now, what about chronic lung disease, chronic pulmonary aspergillosis? Here's an example of one patient with TB with unilateral disease on the left and chronic pulmonary aspergillosis on the right. And you can see these images are different, with the one on the right showing clear-cut cavitation with a thick walls and pleural thickening. But it would be easy to treat both of these patients for tuberculosis. And we did one study, and there's another study from AIMS in Delhi, looking at patients who come back to treatment having cured their TB. They've had their treatment, they're better, and then they have new symptoms. And the rate of chronic pulmonary aspergillosis in Vietnam was 52%. And in Delhi was 57%. So the returning patient is a significant group of patients who probably have chronic pulmonary aspergillosis. The clinical features include hemoptysis. That's more common in patients with chronic pulmonary aspergillosis, particularly cavitary form like here. They have a cough, short of breath, they're tired, they lose weight. So many features like tuberculosis, but they less commonly have fever and they more commonly have hemoptysis and significant hemoptysis. And the radiological features are pleural thickening, cavitation, and pericavitary infiltrates. Often there's multiple cavities, although sometimes there's only one. And if you do a CT scan on these patients, you see in the inside of the cavity, and here you see on the left side of your screen and the patient's right upper lobe, you can see some irregular areas around this cavity, and this is all fungal growth within this cavity. And this is different from the other cavity on the other side that was formed by an NTM infection and the bully that this patient also has with COPD and emphysema. And having 2 or 3 underlying lung diseases as well as CPA is very common. So these patients only occasionally have one problem. They usually have 2 or 3, sometimes more lung problems. So there are 3 elements required for the diagnosis of CPA: is a chest X-ray or CT scan that's suggestive of CPA, compatible symptoms, although early in the disease course, there's very few symptoms. It's very quiet. The symptoms appear later, so it may be difficult to discern symptoms related to CPA. And then the majority of patients have a raised Aspergillus IgG level. And so this study of about 200 patients from Indonesia looked at all 3 of these. And in this study, 12.8%, nearly 13% had CPA at the end of their TB treatment. Okay, so you've got the group who have come back with new symptoms after the end of TB treatment, and then you have this group at the end of their TB treatment, they're finishing TB treatment, and they have CPA. One of the tests that you can do is this lateral flow test, which is for antibody. It picks up IgG and IgM, and this was evaluated in Chandigarh. It's also been evaluated in other countries and populations, and it's pretty good. It's around 90% sensitivity and around 80 to 90% specificity. So this is a helpful test. It's inexpensive, and if it isn't available to you in your local TB clinics, it can be purchased. The French company that makes it sells it for $4 per test, so it's inexpensive. So taking lots of data that have been published in the last 10 years, my colleagues Donald and Animesh tried to re-estimate how many chronic pulmonary aspergillosis cases there are in India. So we looked at different categories of these to make this modeling approach. So the first was patients who are misdiagnosed as having pulmonary TB, because some patients who are gene expert negative, smear negative, may actually have TB, may have CPA and not TB. And we think that rate's around 20%. And then there are patients who have dual infection or co-infections, not very many, but a few. Then there are patients who I mentioned who exit their TB treatment with CPA. That's the 12.8% from Indonesia group. We looked at those who died, and I'll show you that in a minute. And then we looked at those who come back, as I've mentioned, with CPA after they finished TB and had treated, and then what proportion of those patients died. So we then looked at all of the publications looking at with case series of CPA at what the mortality of this disease was. And there's quite a lot of variability in these studies. Some are inpatient studies only, some are quite small, some are large. The studies from Northeast Asia, Korea and Japan tend to be quite a lot older patients. So there's a lot of variability, and therefore there's some uncertainty, but in all cases, the diagnosis was made. So you've got some situations where the diagnosis is not made and the outcome will probably be worse. So we've estimated in this new piece of work around 20% mortality in year 1 and 7.5% mortality each year thereafter. So that tells you that CPA is not a good disease to have. That's as bad as many of the cancers that we have. And I've done a simple calculation using the model that we used for India for Sri Lanka, and you can see that we think that there's around 1,480 misdiagnosed patients who are currently diagnosed as having TB, but actually probably have CPA. That's based on data from Nigeria, so we need that data from your country. And then co-infection cases, probably about 62 patients, 3%. There's not much support for that piece of information. This is probably a conservative estimate, this 3%. It may be a bit more than that. And then the ones who exit their TB treatment, we think there's around 800 of those, and we've used a figure of 10%, not 12.8% for that estimate. And then those who are left with cavitation at the end of their TB therapy, and then they come back, the rate, we did a careful piece of work in Uganda with a cohort that was followed twice, and around 6.5% each year of those with cavitation get CPA, and 0.2% of those without cavitation. Overall, when you calculate all of that, that looks like you may have as nearly 10,000 patients in Sri Lanka with chronic pulmonary aspergillosis, and as many as 990 deaths, although that's more than your current TB deaths. So this needs to be taken with a pinch of salt, and we need some more data from your country to be confident of that. So the last topic area I want to touch on is fungal asthma. And I've got one slide about Aspergillus bronchitis. So fungal asthma includes ABPA, allergic bronchopulmonary aspergillosis, but also this other group of severe asthma with fungal sensitization. And SAFS is something that responds to antifungal therapy. So if you have a patient with difficult to control asthma, needing steroids, exacerbations, test them for fungus. If they're positive, you can do a trial of antifungal therapy, and that may be transformative for those patients. I've seen patients who have been in and out of hospital on steroids half the time or more, or continuous steroids, completely transformed with antifungal therapy, usually with itraconazole, occasionally voriconazole. So think about that as a problem for your problem asthma patients. This study of ABPA in Shanghai looked at whether the patients did or didn't, what age they were, whether they had asthma or not. And you'll see that there's a group of patients, quite a lot of the patients did not apparently have asthma in ABPA. And you can have ABPA with very mild asthma or no asthma. You also can have misdiagnosis as TB. You see the 21% in all patients were misdiagnosed as TB, and that is well described in India as well. And then from a radiological perspective, you have patients with central bronchiectasis, mucoid impaction, which is you have to look at the bone windows to see that. You won't see that on the lung windows. And then a lot of these patients have chronic pleuropulmonary fibrosis. And my suspicion is that many of them actually have chronic pulmonary aspergillosis, and they don't have ABPA, they just have a raised IgE. And the delay in diagnosis of these patients in Shanghai was common, so 41% took more than a year to make the diagnosis, and some were still undiagnosed at 10 years. And the last disease entity is Aspergillus bronchitis, which in essentially normal people, although frequently those with bronchiectasis. And as I don't need to tell you, bronchiectasis is common, particularly amongst post-TB patients, and you can get this airways infection in the lungs, which is quite important, and again responds to antifungal therapy. And they don't have significant radiological findings of CPA. They don't have major ABPA problems or raised IgE. They can have mucus impaction. They present often very breathless with recurrent chest infections. And so the diagnoses that to make these allergic diagnoses, you're looking at IgG antibody and IgE antibody to Aspergillus, or if IgEs to other fungi like Cladosporium, Alternaria are commonly positive. And you may get positive cultures in these patients, but PCR is probably more sensitive. Aspergillus bronchitis, it's about finding the fungus in the airways, either by culture, PCR, microscopy. Those are the most helpful tests. So finally, when you decide to treat with antifungals, you need to give consideration to antifungal drug interactions. And we have an app which is available on Android phones, or you can search on the Aspergillus website or the Life website, and you can search for interactions. And there are 541, or were 2 years ago, severe interactions, potentially life-threatening or forcing hospitalization with these drugs. So you really need to check for drug interactions. And as a resource for you to help with understanding the tests, lots of videos, radiology, basic information about fungus, this website, thefungaleducation.org, may be of value to you. With that, I will stop, and thank you very much for your attention, and I'm happy to answer some questions.
So that was a fascinating insight into a emerging infection which has better diagnostics and better treatment now, and something that we need to look at, I think, in our patients. So let's move on to the third talk. It's titled Pneumonia in the Solid Organ Transplanted Patient, and it will be delivered by Prof. Tobias Welt from Germany. He is the Professor of Pulmonary Medicine and Director of the Department of Pulmonary and Infectious Diseases at Hanover University School of Medicine in Hanover, Germany.
Yeah. Hello and good day to Sri Lanka. It's a great pleasure to be invited to give you a talk, which I will look to a broader topic, respiratory infections in the immunocompromised host, with a focus on solid organ transplantation. We published a recommendation paper some years ago, and my special thanks go to Julio Ramirez from the US, who organized it, about the treatment of pneumonia in immunocompromised adults. And to make a very long story short, this is a very complicated topic. And the main reason why it is so diverse is that different types of immunosuppression make you more susceptible for very different infections, and so need different diagnostic and therapeutic approach. And to make it more clear, if there is more T-cell immunosuppression, which is typical for the organ transplantation, T-cell prone diseases are more frequent. And if there are B-cell immunosuppression, for example, rituximab anti-CD20 as a very often used treatment of autoimmune disease and rheumatological diseases, B-cell related infections are more present. And the best example for the last one is the coronavirus pandemic, and I will focus on this a little bit during my talk. So as you can see here, there are a lot of immunosuppressive reasons for different diseases, beginning with HIV and ending with organ transplantation. And I only want to point out one of this, and this is corticosteroid maintenance treatment. This is something which is really underestimated. And it's quite clear, if you are prednisolone maintenance treatment, and this is still very often done also in respiratory medicine, more than 15 milligrams of prednisolone equivalent is a substantial immunosuppressant, and the main risk factor for what you have heard in the recent talk, diseases related to aspergillus, fungal diseases of the lung, which are not easy to treat. So what about patients with malignancies and hematological malignancies? And these have been the strategy in hematology oncology for a very long time, and in part it had been transferred into the management of patients with infections after solid organ transplantation. So early combination treatment, when fever, when signs and symptoms of infection occur, had been used primarily, and then in a very early phase of treatment, MRSA-effective antibiotics and antimycotics had been added. However, and this is always the same, if you overuse antibiotics, more and more multi-resistant pathogens occur, mainly on the gram-negative side, MDR gram-negatives. The resistance to antibiotics had been raising, and antibiotic side effects, and I only want to focus on one antibiotic-induced diarrhea with Clostridium difficile infection, have been more and more present and causes other problems. So with this in mind, the strategy changed. And this is true for all patients who are immunosuppressed. So we do not recommend today a combination treatment in patients with who are diagnosed with an infection, but when no pathogen had been found, we offer empiric antibiotic, mainly monotherapeutic treatment. And what we use in Europe is mainly piperacillin, tazobactam, having in mind that in your country, in Asia, in India and Sri Lanka, there is a high resistance pattern with regard to piptazo. However, when we increase the starting antibiotic therapy to a carbapenem, mainly meropenem, carbapenem resistant strains come up more and more. And as you know, all this is a real problem on the Indian subcontinent. What we want to avoid, mainly in patients who are immunosuppressed, is to use aminoglycosides or colistin in the initial treatment option. And the main reason is that, and this is really true for the transplant patients, most of them, due to the immunosuppressant agents used, are in renal failure. Calcineurin inhibitors, tacrolimus, cyclosporin are nephrotoxic. And if you add a nephrotoxic antibiotic, this increases the risk of renal failure. As I said before, what we have to differentiate is between T-cell guided or leaded immunosuppression and B-cell focused immunosuppression. And one of the diseases we had a lot of trouble with during the last months and years was SARS-CoV-2, the coronavirus pandemia, which is a typical B-cell focused infection. So if there is an immunosuppression which suppresses the B-cell system more than the T-cell system, there's more severe coronavirus disease and a higher mortality. And this had been shown in a number of papers, and I show you some of this coronavirus disease in solid organ transplant recipients, and there had been an increase in those who are infected, an increase in severe complications, and also an increase in mortality. And when SARS-CoV-2 started here in Europe, and my department, Hanover Medical School, is the biggest lung transplant center in Europe, we had a mortality in lung transplant recipients around 50%. If you look to transplantation and the risk for coronavirus infection, renal transplantation, renal recipients are most at risk, followed by lung, heart, and liver. And very surprisingly, stem cell transplantation does not increase the risk for severe complication of coronavirus disease. Well, I want to show you some of the data for lung transplantation, all demonstrating that there is an increased risk for mortality. And what you can see here, the risk factors present outside the immunosuppressive patient group are the same in the immunosuppressive group. So overweight, adipositas have been shown to be a major risk factor in coronavirus disease. And the same is true for males. So male had a worse prognosis in comparison to female. And what is obvious, if there are bronchial complications after transplantation, the risk for severe course of the disease increases. So what we learned during the last months of coronavirus pandemia is that bacterial superinfection plays a role, as it has been known for influenza first. And the bugs which are present here are the classical gram-positive pneumococcal disease, Staph aureus infection on the one hand side, and with these gram-positive agents, more with Omicron than we had seen it with the older variants, and gram-negative superinfection 5 to 10 days after coronavirus infection started is also a complication. And then what had been seen mainly on the Indian subcontinent is secondary fungal infection. There are a lot of reports about invasive aspergillosis, but also invasive mucormycosis in patients suffering from COVID. And the main reason why this is present in Asian countries more than in European countries is the usage of corticosteroids to treat COVID-19 and to use corticosteroids in higher dosages. So in Asia, higher dosages had used for a longer time in COVID patients than the 6 milligrams of dexamethasone for 10 days recommended in Europe and the US. And this had led to an increase in invasive pulmonary fungal infections. So we have a lot of possible treatment options for COVID-19 in our days. And for the transplant patients, I want to recommend some of them. So if someone after transplantation is infected with SARS-CoV-2, you should immediately start antiviral treatment, if possible with an oral agent, which could be molnupiravir or nirmatrelvir. But if you use Paxlovid, you have to have in mind that there is an interaction with the calcineurin inhibitors and mainly cyclosporin and tacrolimus, and you have to control plasma levels of the immunosuppressants by far. It's well known that a second agent used to protect for chronic rejection in transplant recipients, which is mycophenolate, increases the risk for severe COVID infection. So normally, if there is a COVID infection, we reduce the mycophenolate doses, we start an antiviral, and when there is respiratory failure appearing, we start dexamethasone treatment. For a long time, we could use monoclonal antibodies, and this is a paper out of my group demonstrating that they have been very effective in the alpha and delta time. But with Omicron, the picture changed. So most of the monoclonal antibodies are not working anymore in Omicron, mainly with regard to the BA4 and BA5 subvariants. And at the moment, we do not use monoclonal antibodies anymore. What we did when we had a lot of patients with respiratory failure after transplantation on the ICU with coronavirus disease, we started lung transplantation for this in those who are only suffering from a mono-organ failure, so only the lung is impaired. And if this is the case, we tried mainly for the younger patients to overcome respiratory failure by transplantation. And this is the first series published by Konrad Hötzenegger from Vienna. However, altogether, the results are not very fine. There is a 50% mortality, and we got a lot of insights into the pathology of the COVID lung, but not favorable outcomes for the patients. Coming back to the immunosuppressant patient in general. And as you can see, a lot of infections who are not commonly seen in patients who are not immunosuppressed could take place. And you can see here some of them. So you have to have tuberculosis in mind, viruses, mainly CMV, cytomegalovirus plays a role. And then there is a lot of fungal infection. We here in Hanover, we use cotrimoxazole prophylaxis, and with this, we did not see a lot of pneumocystis cases, but pneumocystis is something you have to have in mind. And then there is a broad picture of fungal infection in those patients. I want to focus you on things which you may not have in mind. So tuberculosis is a finding after transplantation, but a lot of tuberculosis-like infections are caused by nocardia spaces, and you should start a specific diagnosis, PCR diagnosis for nocardia, because it's not a rare event. As you will have a look into our recommendation paper, there are tables with specific diagnostic procedures for different pathogens, and I do not want to explain it in detail during this talk. During the last minutes, I want to focus on fungal infection. Fungal infection in the transplant group is something which is very, very often seen and very present, and the diagnostics may not be easy. So standard diagnostic procedure is CT scan, and mainly aspergillosis, but also mucormycosis shows a classical picture of a necrotizing consolidation in parts of the lung. Biomarkers are established. The most important one is galactomannan. Galactomannan in serum is not very specific. It's better to have a galactomannan out of BAL, bronchoalveolar lavage. However, you should run a CT scan before, because you have to perform the lavage in the segment which is affected by aspergillus. And serology normally is not very helpful in diagnosis. So in general, we suggest to extend empirical therapy beyond co-respiratory pathogens when multi-drug resistant pathogens are possible or empirical therapy failed. For India, for Sri Lanka, the prevalence of multi-drug resistant pathogens like MDR, Klebsiella, or Pseudomonas has to be taken into account. Well, what I said before, and I want to repeat it. So we start with anti-infective treatment with antibiotics. If there is signs and symptoms of fungal infections in the chest X-ray, antifungal therapy should be started very early, and in severe infection, mainly mycophenolate, must be stopped. We have a number of guidelines for invasive aspergillosis, and they are all very similar in terms of first-line treatment, which is voriconazole, and you can see the dosage here, or as a new alternative, isavuconazole, which is better penetrating into the lung. And if this does not work, liposomal amphotericin B is an alternative. And again, this has been recommended in a number of papers. So voriconazole had been shown to be superior to amphotericin B, therefore it's first-line therapy. However, it's quite clear voriconazole is metabolized very individually. And so you need drug monitoring to find the right dosage. And it's very hard to estimate who needs higher dosages and who needs lower dosages. So voriconazole drug monitoring should be established everywhere where invasive aspergillosis had been treated. For mucormycosis, there is a bigger data set for the use of isavuconazole, and isavuconazole have been shown to be minimally as effective as voriconazole, but with less side effects. And so we use it in first line, and this is the main paper demonstrating the similar efficiency by lower side effect rate. And even for isavuconazole and another agent, the oral drug posaconazole, you need drug monitoring because it's so hard to estimate the metabolism. Normally, invasive aspergillosis, invasive mucormycosis has to be treated long-term, treatment cycles of weeks and months until there's nothing to see in the chest CT scan anymore, which could be a starting point for reinfection, is the normal treatment cycle. Combination therapy is very often used in antifungals, so to combine an azole derivative like voriconazole with an echinocandin, but to be honest, there's no data about this which could support the usage of combination therapy in general. So to conclude, antibiotics treatment has been specified for immunocompromised hosts, starting with monotherapy, taking the problem of multi-drug resistancy into account and choosing the adequate treatment related to the diagnostic procedure you heard about in recent talks. The difference in local epidemiology had to be taken into account. And so also for the immunocompromised host, we need an antibiotic stewardship program and to bring in the experience of infectious disease specialists into this field. And with this, I thank you very much for your attention. I'm open for questions. Again, thank you for inviting me, and all my best for the physicians, the scientists, the people in Sri Lanka. Thank you very much.
Thank you for dealing with the wide range of pathogens and many new emerging pathogens in the background of solid organ transplantation. We move on to the final speaker. The title is Moving Forwards in the Treatment of Tuberculosis. And the speaker is Dr. Kirti Gunasekara, consultant respiratory physician in Colombo.
Thank you, Inoka, for that kind introduction. And I wish to thank the college also for inviting me to speak on this topic. I will be focusing on the rationale of the changing the WHO guidelines in the treatment of tuberculosis when speaking about moving forward in the treatment. And sorry. Oh, sorry. Right. So if we just have a look at the global trends of tuberculosis, still we have about 10 million people per year being affected by TB. And we know that it is a leading cause of infectious disease. It's a killer. And it's responsible for about 1.2 million TB deaths amongst HIV negative, and HIV positive TB, again, we have about 200,000 deaths. And approximately 70% are diagnosed and treated. So a lot of people are not diagnosed. A lot of TB is undiagnosed. When it comes to Sri Lanka, it was highlighted that we have about 7,000 cases every year yet, and we have around 800 deaths still, despite all the medication and all our efforts. We are still having this amount of deaths going on. So it is still quite a large number. And if you just look at this, you'll find that the WHO recommended rapid diagnostics, we have only about 24% coverage. So which is, just keep that in mind, because it is important when we move forward in the treatment of tuberculosis that we have available the diagnostics. And this, if you look at this, these graphs, you'll find that if you take the prevalence of TB, you'll find that the graph has not gone down at all over 2 decades. So it's a long period of time. So this is not something that we can easily overcome. We have to be aware of this. And if you look at the deaths, again, it shows a downward trend, but over 2 decades. But again, it is not a very steady decline that we see, despite so many interventions that we do in our country against tuberculosis. So when you look at the treatment, again, for the past 20 years or even more, we find that still we are using the same drugs. Still, the INH, rifampicin, ethambutol, and pyrazinamide are in the forefront. And the 6-month regime, and this regime is well known and adopted worldwide for decades. And we have about 85% successful treatment outcomes, which is not too bad. But the thing is that we have not gone any further from that, because if you look at the guidelines, you find that the guidelines have gone from 2012, 2010, 2017, 2019, but there have not been really very many changes in the drug treatment. Why is this? If you just look at the basics, you find that rifampicin and INH are still the most potent bactericidal drugs against tuberculosis. So because of that, still they hold good. And as first line, pyrazinamide and ethambutol still come into the play. And the treatment, we have the intensive phase and the continuation phase. And this is, all of you are familiar with that. So for the intensive phase, you'll be using the 4 drugs, and then the continuation phase, the 2 drugs. But in Sri Lanka, for relapse cases, we will extend the intensive case by another month and extend the continuation phase to 5 months, which is not recommended in the new guideline. And we have, of course, the introduction of the fixed dose combinations. It seems simple, but it has improved compliance quite a bit, and therefore the recovery from tuberculosis has improved greatly because of the fixed dose formulations. And these are the FDCs, we call them the FDCs, that are available. But however, unfortunately, I think the FDC3 is now being phased out in the world, and we might have a problem in procuring the FDC3 in the future for our continuation phase in relapsed patients. So in the intensive phase, we use 4 drugs, so there is rapidly killing of actively multiplying bacillary population, and we use it for 2 months, and the smear conversion is about 90%. So it is very important that to start the patient when he's smear positive on anti-TB drugs as soon as possible, because within 48 hours, the infectivity drops by almost 85%. Right? So this is greatly underestimated, and still we delay the treatment everywhere, and therefore it perpetuates the existence of this disease in the community. And because it greatly reduces the infectiousness, that is the rationale of treating the TB patients at home as well. Because you might be wondering why we send them home for treatment. It is because their infectiousness drops down drastically the moment you start on the intensive phase. And of course, the continuation phase. Why do we have the continuation phase? But this is to eliminate the persisting bacilli, and the dormant bacilli get activated with time, and we will be able to knock off the persisters. When you take the 2022 guideline, still they recommend that pulmonary TB should receive a regimen of 6 months of RHEZ. This is what we said, the 4 drugs for 2 months and 4 drugs for 2 months and 2 drugs for 4 months. And earlier we had the option of having thrice weekly dosing, which Sri Lanka never adopted this, but it is no longer recommended. Daily dosing is vital, and it is the fixed dose combinations is recommended over separate drugs, unless of course you have problems like hepatic involvement and renal involvement where we have to use separate drugs. And it is recommended that if you are using a regime containing rifampicin throughout treatment, if a positive smear is found at completion of the 2 months, the extension of the intensive phase is not recommended. But we are not following that. That is, at the end of 2 months, you find that it's smear positive. If you've been using rifampicin, they say, please, you can not continue the 4 drugs, but go down onto 2 drugs. But unfortunately, for this, before you're doing that, it is required that you do sensitivities. And the drug sensitivities we cannot do easily on all patients yet, because we know that we use the gene expert now to look for rifampicin resistance. But then again, that is not done on all patients because we don't have the resources to do that. It is hoped that we will be doing it soon, but it is not only for rifampicin, but we have to do it for other drugs as well. Now, the newer recommendation is also to shorten the treatment regimen some more, because obviously when you have to take drugs for a long time, there will be default. It's not easy to continue. And though the DOTS program is being implemented, it is very difficult to implement the DOTS program very successfully because supervision is very difficult. So they are trying to cut it down to 4 months, and they'll be using INH, rifampicin or rifampicin, moxifloxacin and pyrazinamide for 2 months, and without moxifloxacin to continue the other 3 drugs for 2 months. But the problem with this is you need to do drug sensitivity testing at the beginning, which we don't have the facility for, because now there is provision to have your gene expert to test the XDR drugs, that is all to test all the drugs for sensitivity, and that it will be very much easier to know whether you are dealing with a drug-resistant TB or a drug-sensitive TB. So it is without that facility, it's going to be difficult. And also, if we are using the 4-month regime, we need to have daily DOTS supervised very carefully in all these patients, which is not an easy thing, because we don't have fixed dose combinations for these drugs yet, and therefore they'll have to swallow a whole heap of drugs. I can remember those days when we started treating TB, they used to have 16 pills in the hand, and half the pills are in the drain when you go, even in the morning, because they just think that it's useless swallowing all these pills. So we have this problem. So this and the cost of moxifloxacin to be used is also going to be very, very much. And also in this regime, it has to be taken with food. And that is also another problem, because we underestimate the poverty that is existent amongst our TB patients, because most of them are, they can't have all 3 meals, and the economic situation in the country is also bad. So this is also a problem globally, not only in Sri Lanka. So this is a requirement of evaluating the testing for the 4-month regime and the standard 6-month regime. A baseline test for at least 1 specimen using rapid molecular test is advisable for all these drugs, INH, rifampicin, pyrazinamide, and the fluoroquinolones, which is not available for us, and hence we will not be embarking on this 4-month regime soon. Now, apart from that, for people, drug susceptible treatment with ART, antiretroviral therapy, it's the same duration as for the HIV negative, and ART must be started as soon as possible, regardless of the CD4 count, because it will help to recover both diseases. And steroids, as you know, have been recommended. This we are already practicing for TB meningitis, pericarditis, and also we use it for all other pleural and peritoneal TB we use to prevent adhesions. This is still recommended. Now, the treatment of relapses, this is what I told you earlier, that earlier we used to call it category 1 and 2, but now the category 1 and 2 is not used. That terminology is not used. I will tell you, because earlier, the category 2, we used streptomycin. Streptomycin was a very useful drug, but now studies have shown that the mortality nor the recovery rates have improved with streptomycin, and hence streptomycin has been taken away from the first-line drugs. And but still, it is used sometimes in certain retreatment cases while waiting for culture and ABST, and also with a history of second relapse, and in treatment failures sometimes, and in TB meningitis rarely. And also sometimes when we have problems with hepatotoxicity, we'll be using streptomycin. Now, when it comes to drug-resistant TB, remember that there are so many different kinds of drug-resistant TB. So we have the INH resistant, but susceptible to rifampicin. Monoresistance, there is resistance to one first-line antituberculous drug. Polyresistance is resistance to more than one antituberculous drugs, but other than INH and rifampicin. Because the moment INH and rifampicin come into the scene, it becomes a multi-drug resistant tuberculosis. So that is the basic rationale of this. And here we can't, in Sri Lanka, we can't test for INH resistance on the gene expert. We have to do the cultures, and unfortunately, I think our line probe assay is also broken now, so that also hampers us further in diagnosing INH resistance. But if you are resistant to rifampicin, we take it as MDR-TB here in Sri Lanka, and we start them on the regime. So what is XDR-TB? That is, apart from being resistant to INH and rifampicin, also for fluoroquinolones, it's resistance. And the extensive, the XDR, that's a pre-XDR, and in XDR-TB, you find that I'll show you the second-line drugs. One of the group A drugs are also additionally resistant. So globally, we are having a problem of drug resistance, and this is a huge problem everywhere. Fortunately, we are not having that many MDR patients at the moment in Sri Lanka. I think it has been always below 20. So I hope and pray that it keeps like that. Otherwise, we are going to have a lot of problems in managing this. So these are the three categories of second-line drugs that are used: levofloxacin, aquinolone, bedaquiline, and linezolid. And in group B, you get clofazimine, cycloserine, or teridazole. And group C, you get these other drugs. And these are the ones that we use for treatment of multi-drug resistance. And if the patient is INH resistant, we use rifampicin, ethambutol, pyrazinamide, and levofloxacin for 6 months without INH. And for treatment of MDR-TB, you have the longer regimes, which is going on for 18 months, or you have the shorter regimes. So if you have any contraindications that you can't use the shorter regimes, then we go for the longer regimes. So if the rationale of treatment, again, all 3 group A agents and at least 1 group B agent should be included, and at least 3 agents are included for the rest of the treatment after bedaquiline is stopped. So bedaquiline is one of the most important drugs in the treatment of MDR-TB. And these are the must includes and the may includes. So you can see that the group A drugs are the must includes in this. and you may include the others, but not the kanamycin and capreomycin and clavulanic acids are not to be included in the future in the drug resistant regimes which we used earlier. So duration, as I told you, the longer regimes were 18 to 20 months, and the shorter regimes have been limited to 9 to 12 months. And we have to do cultures every month and direct smears every month when we are treating drug-resistant TB. And antiretroviral therapy is recommended in all HIV drug-resistant TB, and irrespective of the CD4 count, we will start the anti-TB drugs. And we can use partial lung resection if it is very localized to one area. And this is what I said, that first we will start the patient on short-term regime for MDR. And there are lots of things that, lot of contraindications for the short-term regime. If you have liver failure, renal failure, pregnancy, young children, then you can't give the short-term regime, and then we have to go for the longer regime. And the principles of treatment are similar to the longer regimes. And this is what I have shown you is 4 to 6 months of levofloxacin, bedaquiline, and clofazimine, ethionamide, ethambutol, pyrazinamide, and high-dose INH are used, and the rest you stop the bedaquiline and go use the rest for 5 months. And those who are not eligible for the short course, then we go on to the longer term regimes, particularly for severe forms of TB and with resistance to fluoroquinolones. And here it's 18 months of bedaquiline. You use it for 6 months and continue with the moxifloxacin and the linezolid and the clofazimine. So this is a longer term regime that is shown. And if you have XDR TB, it is recommended, still this is as an operational research, 3-drug regime for 6 to 9 months. We are trying to make it less drugs and shorter regimes for compliance because it's very important. So this is a suggested thing. And if not, there are very complex regimes that are suggested. So in conclusion, treatment of tuberculosis poses a continuous challenge to mankind with multitude of obstacles. Treatment compliance is one of the biggest problems, drug resistance, HIV co-infection, financial constraints, and the resilience of the bacterium itself. We have to understand that the TB bacillus is a very, very strong bacillus, right? And there are a lot of obstacles when we try to treat the bacillus, because every time we try to control it, even in the most developed countries, you find, even in Singapore, you find that tuberculosis control is not very good, right? So it is not an easy task that we have, and we have to have a very good system to get this disease under control. Rapid diagnostic and more efficient pharmacotherapy and novel combination of medication based on continuous research are some of the strategies that have evolved to strengthen the guidelines to combat these challenges. So it is an ever continuing challenge for us to control tuberculosis. So it is no easy joke, and this will be changing all the time. But of course, I think we have been somehow coping with it, and I hope that we will be stronger to combat this disease in the future. Thank you.
Thank you, Dr. Kirti. Please do take a seat. Thank you for updating us on what seems to be an evolving process of treatment of tuberculosis. Please join us, Dr. Thamila. We have a few minutes for questions from any of the 4 speakers. Professor Tobias is online if anyone has a question.
Yeah, Professor Tobias. Yes, I'm Dr. Adhavan. So this is regarding the empirical treatment of pulmonary infection in a patient, in a solid organ transplant recipient who is developing a pulmonary infection. So we always have a challenge of establishing the microbiology diagnosis despite invasive microbiological sampling, because of the fungal cultures, the sensitivity is quite low. So, even when we had to wait for some time before starting on the treatment. So what are your thoughts when we suspect a mixed infection? So would you suggest guiding our antibiotic therapy based on the radiology, or else a hit hard approach?
Yeah, that's a very good question, and I will give you, let me say, a step-for-step recommendation. First, still in transplant, bacterial infection is mostly present. About 80% are bacterial infection. So you should start antibacterial treatment and have your local resistance patterns in mind. Secondary, if there is a disbalance between markers of biomarkers of infection, CRP, PCT, with the presentation of the patient, you should have other kind of infections in mind. In lung transplant, it's Aspergillus and it's CMV. And we normally make a CMV diagnosis. We use numbers of copies out of BAL, and we run a CT scan. For CMV and aspergillosis, CRP and PCT levels are lower than for bacterial infection. But if there's no hint that it is a fungal or a viral disease, from further observation, we do not start empirical antimycotic treatment from the beginning on. This is radiology imaging focused. But for every lung transplant recipient who comes with a suspicious infection, we do a BAL and try to set up a proper diagnosis.
Can I also ask just a further thing on imaging? How sensitive would you find necrotizing pneumonia to think of a fungal etiology and fungal markers like the Aspergillus galactomannan and the beta-glycan? How useful do you find them in?
So the CT imaging is not 100% confirming. The sensitivity is about 80%. And there are differential diagnoses you have to have in mind. And for necrotizing consolidations, this could be Staphylococcus pneumonia, which also is necrotizing, mainly when it is a PVR pathogenicity factor, and there are other possible differential diagnosis. So we always try to use the CT and confirm the diagnosis by galactomannan out of BAL. But if it could be fungal infection and you do not get a confirmation, you have to treat it in an immunosuppressed patient.
How much of a problem is a false positive galactomannan? We find some patients who are on piperacillin tazobactam. Do you go by titers, or how do you find you are saying in BAL or serum as well? Sometimes it's not possible to do BAL in these patients.
Yeah, so I try to get galactomannan for confirmation, but if it is negative and the serum galactomannan is not very sensitive and the CT is likely to be invasive aspergillosis, I start treatment. And then you have to re-evaluate after a week. And if it is not recurrent, if you do not see any treatment success, you have to start a new differential diagnosis route.
Just on the final question, sometimes in post-KT patients, we find CMV and PCP co-infections. When we look at the HR resolution CT scan, when we see centrilobular ground glass density nodules, we tend to think more towards CMV infection. Is there any like truth in this or?
Well, ground glass pattern in transplant recipients is very hard to interpret. Yes, if it is could be CMV, you should take it into account. But we normally use the CMV early antigen out of serum, and we try to get a CMV detection by using copies in BAL. So we use CMV PCR as a diagnostic procedure in the transplant group, but for example also in HIV, where CMV infection very often occurs.
What is the cutoff for invasive CMV disease when we are interpreting the CMV PCR results from the blood?
Yeah, there is no clear cutoff. If it is more than 100,000 copies in serum, it's confirmed in my mind. From 10,000 on, you should monitor it, and then we do a second CMV diagnostic some days, a week later, and when it is increasing, it has to be treated.
Okay, I think we've run out of time now for questions, so it remains for me to thank our speakers for sticking to time, for giving us so much valuable information. And let me hand over a token of appreciation to each of the speakers.